So today I'm going to present on two abstracts that were presented on the secondary hormonal use in men with non-metastatic castrate-resistant prostate cancer. The first one is the PROSPER trial and the second will be the ASIM trial. So let's start with the PROSPER trial. The PROSPER trial was a phase 3 randomized double-blinded placebo-controlled study of enzalutamide in men with non-metastatic castrate-resistant prostate cancer. Just to remind you of the study design, in this cohort of men, they had a rising PSA despite a castrate testosterone level of less than 50 nanograms per deciliter. Their baseline PSA was over 2 nanograms per mil, and the PSA doubling time was less than 10 months. The study group was stratified into PSA doubling time less than 6 months versus 6 to 10 months, baseline use of bone targeting agent, yes or no. So their primary endpoint was metastatic free survival, and this was defined as a time for randomization to radiographic progression or death within 112 days of treatment discontinuation without evidence of radiographic progression. After a positive attainment of this primary endpoint, an open label extension was optional, in which the placebo group were allowed to cross over into the enzalutamide arm and receive 160 milligrams of enzalutamide per day in addition to the ADT. Today we present the secondary endpoints of overall survival, time to PSA progression, the safety profile, PSA response, and of course the quality of life. So after a median of 48 months follow-up, the ADT plus enzalutamide arm resulted in a statistically significant 27% lower risk of death. The median survival, as you can see from the graph here, was that there was a 67-month survival in the Enza group compared to 56 months in the placebo group. In terms of subsequent antineoplastic therapy, the most common subsequent therapy for the Enza group was docetaxel, and for the placebo group, that was abiraterone. But of course, there were other agents that were used, like cabazitaxel, bicalutamide, and of course, the crossover group who got enzalutamide later. The median time to first use of subsequent antineoplastic therapy was 66.7 months for the enzalutamide group, compared to only 19.1 months for the placebo group. So clearly here again you had a statistically significant difference in this value. In terms of adverse events of special interest, the most common adverse events in the Enza group were fatigue and muscle aches. The cardiovascular events for the Enza group and the placebo group, as we know, the safety profile of these agents were not too different: 3 in 100 patient years for the Enza group and 2 in 100 patient years for the placebo. In summary, these updated findings show us that in patients with non-metastatic castrate-resistant prostate cancer, enzalutamide treatment resulted in a clinically meaningful and statistically significant 27% lower risk of death than placebo. These results demonstrate that enzalutamide prolongs overall survival compared with placebo in men with non-metastatic castrate-resistant prostate cancer and a rapidly rising PSA. The adverse events were consistent with the established profile of enzalutamide. This study was published in the New England Journal of Medicine. The second study that we'll discuss today, or the second abstract that I'll present to you, are the results of darolutamide, the use of darolutamide in addition to androgen deprivation therapy in the same group of men. So this also was a double-blinded placebo-controlled phase 3 trial, and the profile of the patients were very similar, and the characteristics of that as well as the stratification. So the primary endpoint, which met statistical significance, was metastatic free survival, which was 40.4 months for darolutamide versus 18.4 months for placebo, which was quite significant, and it had a favorable safety profile at this primary analysis. The secondary endpoints assessed and presented today were the overall survival, time to pain progression, time to first cytotoxic chemotherapy, and time to first symptomatic skeletal event. So the ARAMIS overall survival showed a 31% reduction in risk of death. So the hazard ratio for this was 0.69 with a p-value of 0.03%, and you can see there it's 83% versus 77% for placebo versus darolutamide. And you find that in terms of those who received subsequent life-prolonging therapy, there were only 114 patients during this time for darolutamide, and you had 309 for the. So in all the secondary endpoints, the favor was towards darolutamide. For example, time to progression, you have a better profile in the darolutamide arm, which is demonstrated there by the splitting of the graphs. The time to first cytotoxic chemotherapy also shows favor towards that. First symptomatic skeletal effect. In terms of the incidence of adverse effects, fatigue, falls, and rash, unfortunately, were not as good in the darolutamide arm, where you had a greater incidence of falls, including accidents in the darolutamide arm, and you had a greater incidence of the rash. Then when you speak of the cardiovascular events, they were similar, and actually the events matched the discordance in accrual of patients in the study arm. Then there were also some patients who were enrolled into the darolutamide arm who had history of epilepsy. However, the incidence of the adverse effects in this regard were not any different compared to. So what were the conclusions of the ARAMIS study? So darolutamide significantly improved overall survival versus placebo in men with non-metastatic castrate-resistant prostate cancer. There was a 31% reduction in risk of death with a hazard ratio that was statistically significant at 0.69. Darolutamide significantly delayed the onset of cancer-associated morbidities and subsequent chemotherapy versus placebo. The time to progression, subsequent chemotherapy, and symptomatic skeletal events were all significantly prolonged versus the placebos. With extended follow-up time, the safety profile of darolutamide was favorable. Incidences, most of the adverse effects were not increased with darolutamide versus placebo, taking treatment exposure into account. As a result, the authors of this study feel that the results provide compelling evidence for early darolutamide treatment in men with non-metastatic castrate-resistant prostate cancer. And in fact, this has been both darolutamide and enzalutamide adopted in the NCCN guidelines of the treatment of men with prostate cancer. This study was published in the New England Journal of Medicine as well. And that's all I had for you. Dr. Berger will now present two studies on bladder cancer that were presented at this year's ASCO meeting. Thank you.